Welcome and good afternoon. I'm Tina Valentin. I'm the Regional Stroke Education and Data Coordinator for the Central South Stroke Network. And welcome to the final presentation in our stroke series for hospitalists of this year. Today's topic is From Risk Factors to Risk Reduction, Targets and Patient Engagement. So please submit questions in the chat at any time and be prepared to participate in a few polls. So it's my pleasure to introduce Dr. Sharma. Dr. Mike Sharma is the director of the stroke program at McMaster University and Hamilton Health Sciences and holds the Michael G. DeGroot Chair in Stroke Prevention at McMaster. His research interests include the development of new antithrombotic treatments, incorporating magnetic resonance imaging endpoints into the design of stroke prevention trials, and examining the effects of anticoagulants on stroke recurrence and covert brain infarcts. He has led trials and sub-studies in large prevention trials focused on these areas, and currently leads as co-principal investigator the global phase 3 Oceanic Stroke, investigating factor 11A inhibition for stroke prevention in 36 countries. He is the immediate past chair of the Canadian Stroke Consortium, which is the professional organization for stroke physicians and clinical trialists in Canada, and established the stroke program at the University of Ottawa. Dr. Sharma is committed to developing integrated processes for stroke care and developing human and system capacity for the next generation of stroke trials. And with that, I'll turn it to you, Dr. Sharma.
Tina, thanks for that very kind introduction. And I realize I now have to write a short bio. There's a colleague of mine who used to say after being introduced that after hearing that, I can hardly wait to hear myself talk. So thanks very much for joining us, everybody. I have no problems if you fire questions in the chat or if you wish to unmute and speak, that would be perfectly fine as well. It's a small group, and I would rather that you leave with a question answered than us getting through all of the content. Now, two things that I want to say at the beginning. I have no conflicts of interest with regard to the content of this talk. One of the things, just to start with, is this quote from Austin Bradford Hill that I've always liked. So he said, health statistics represent people with the tears wiped off. We're going to look at some numbers that have to do with large populations, but what we actually do is we deal with people, we deal with suffering, we deal with morbidity and death, and we should never forget that as we go through this. Austin Bradford Hill, by the way, was a biostatistician, an epidemiologist who established the link with Richard Dahl between cigarette smoking and cancer and lung cancer. And this was the seminal paper in 1950. Now, that was clearly established then, but it took decades after that to really get smoking traction. The companies, the people who made a lot of money from tobacco fought back very vigorously, and we're seeing something very similar now in terms of climate change. This is a little question that's going to come up at the end. And what you have on the left-hand side are various interventions. Blood pressure reduction.
Dr. Sharma, you're not sharing your screen right now.
I'm not sharing my screen right now. Let me reshare. I have no idea how that happened other than how's that?
Perfect. Thank you.
Other than the ghosts that occupy Teams. So on the left-hand side, you have various interventions: blood pressure reduction, exercise, aspirin. Now, aspirin as physicians is something we routinely do, and we think our job in stroke prevention is done. Statin therapy and drinking coffee. Each of these things result in a reduction of the risk of stroke, and you have on the right-hand side options ranging from 19% risk reduction to 40%. So at the end of this talk, your request will be to put these in order and match up the risk reduction with the intervention. Okay, so let's just talk a little bit about health behaviors and their link to stroke. This is one of the largest epidemiologic studies ever done. It was the Epic Norfolk study, published some time ago, and this is robust, is valid because it followed over 20,000 people with mean follow-up being over 10 years. So you had a lot of data on free-range human beings doing what human beings do, and a lot of time to follow up to establish links between what they were doing and stroke. What this established was significance of four risk behaviors that lead to an increased risk of stroke. First is smoking. The second is a sedentary lifestyle. The third is intake of alcohol. And given the time and place this was done, it was in the UK, being good. So it was having anywhere from 1 to 14 units a week. Now, the British have defined the British alcohol unit, which is 8 grams of alcohol, and 1 glass of wine, a small glass of sherry. This tells you the time and place it was done, a shot of spirits, or half a pint of beer. Now, so one of the things, by the way, I've learned in talking to my patients about alcohol is when they say have a glass, is to figure out how big that glass is. This came to me when the wife of one of my patients pointed out that the wine glass that her husband used actually comprised half a bottle of wine. He said he drank 2 glasses a night, which was 1 bottle of wine. And the last thing on this list is fruit and vegetable intake. 5 or more servings per day is good. So the more points you get on this scale, the better off you are, the lower your risk of stroke. And here's the impact it has. So compared to having a good score on all of them, not drinking, not having alcohol, rather not drinking, not smoking, exercising, and having more than 5 servings of fruit and vegetables a day, if you have none, it more than doubles the risk of stroke. So there is a very significant link between doing these things and the risk of stroke. The rates here are absolute recurrence rates in a year. So you can see that it goes from less than 2% to almost 6%, a tripling of the rate of stroke occurrence. This is a slightly different study called Interstroke Study that was done here at PHRI by a colleague of mine, Martin O'Donnell, and it looks at something called the population attributable risk. Now, the population attributable risk is what proportion of a disease you would remove if you got rid of that risk factor. So it combines the severity of that risk factor with its prevalence, how common it is. So hypertension is a pretty severe risk factor and relatively common. So it has a very high population attributable risk. Smoking is getting less common, but again, a very significant risk factor. And some things that we think of as very high risk, such as diabetes, are relatively low because while they're very common, the impact is not as high as other things. The other point, and I'm not going to address it unless I have questions about it, that is on there is stress and depression. Now, depression occurs in 30% of patients after stroke. So at 90 days, about a third of our patients are depressed. It is a consequence of stroke and also a risk factor for stroke. Depressed people, adjusted for a bunch of other things, are more likely to have stroke than those who are not depressed. So here's the first poll, and I have 3 questions concerning smoking. Tina will launch the poll. It'll pop up on your screen, and please answer, and you have to scroll to get through all 3 of them. First is, how much earlier do smokers have stroke compared to matched non-smokers? So that means that if you had an identical twin that didn't smoke and one who did, who would or how much earlier would the smoker have a stroke? Second is, what's the prevalence of smoking in Canada currently? And the third is, at what age do Canadians develop tobacco dependence? By the way, today is election day, and as they say, vote early, vote often. So please put in your answers. And Tina, let us know when you have enough. So Shalette, Vicky, Candace, everyone, please put in an answer. Stuff's already done.
Okay, we still have a few more responses coming in. Dr. Sharma, can you see the answers?
I can't. All right. Oh, there's a little thing called polls. Do you think I should try clicking on that?
Or in the chat? You might be able to also see it in the chat.
Oh, there it is. Okay, so the first question was how much earlier do smokers have strokes? And we have, the majority voted for 10 years, which is a huge, huge difference. And let's have a look at that. Here are the answers. So the answer absolutely is 10 years for when smokers have strokes compared to non-smokers. This is very valuable for patients because a lot of the time you get a response, gee, if I stop smoking, it will give me 2 weeks or so in terms of life. 10 years is a huge difference in terms of smoking, not smoking. And the next question, boy, so people were all over the board. And the prevalence of smoking in Canada is 11%. Now, the one subgroup where it is still very prevalent is young women. So, lung cancer, by the way, is now past breast cancer as the most common cancer in women. It did so about 10 years ago in this country, and it's because of the prevalence of smoking. Um, there are areas where smoking is much more common. The reason I think that a lot of us thought it was higher is because we happen to live in one of those areas. So, this region has a very high prevalence of smoking. Okay, now, so the next one was, just click on it. Right. So nice. Um, the last question was the age at which Canadians develop tobacco dependence. It is between the ages of 13 and 15. So too young to really, we don't allow people that age to drink, to drive a car, to vote. So too young really to have that facility and agency to make a decision, to get onto something which has drastic health consequences and is hugely addictive. And Vicky, smoking does not include vaping. So smoking constitutes the burning of tobacco. So this is cigarettes, pipes, cigars. And most of it, by the way, is cigarettes, of course. All right. So how do we approach smokers? So Charlotte, does secondhand smoke count? It does. There is a dose relationship in smoking. So the health effects are worse the more you smoke. And secondhand smoke is just a lower dose of smoking. Now, the traditional approach to patients who do things that you'd rather they didn't do was the Presbyterian approach, which, and my apologies to anyone who's a Presbyterian, I mean you no disrespect, but it was a rather finger wagging approach of, do you not know that this is bad for you? That's what I was taught in medical school. Now, at the end of the day, that does not work for a host of reasons. First off, it puts a division up between you and your patient, the person you're trying to help. Secondly, it puts the blame for this addiction and the consequent disease, in this case stroke, onto the patient, which really is not what you want to do. So you want to remove that barrier and be on the same side. A couple of things are pretty apparent. About half of smokers have made a quit attempt in the last year. They happen to have a very low success rate by themselves, about 15% or so. There's no one left on the earth, I think, who doesn't know that smoking is bad. It's not an information problem. It really is an ability and motivational problem. The one huge advantage all of us have who deal with stroke patients is you see people at a teachable moment, and a very brief intervention in that setting can have a tremendous effect. So, the success rate when people do it by themselves is 15%. But when you provide medical advice, that increases abstinence to 50%, a huge benefit. Now, the way you provide it is very important. It's got to be clear, unambiguous, and personalized. So, the way I tend to approach it is to start with, have you ever tried to quit smoking? Just about everyone will say that. And no matter what the response is, my next comment is something along the lines of, it's hard, isn't it? What happened? Tell me what happened. There are people who manage to quit for a year, 3 years, 10 years. They can definitely quit again. The tell me what happened really gets to the second aspect, which is to develop strategies to help them when they have problems once again. Now, one thing to know is nicotine. And by the way, nicotine is not the bad actor in cigarette smoke. It's all the other chemicals, all the other products of combustion that are in there. And there are thousands of them. That's what causes cancer, vascular disease, stroke, and wrinkles as well. Did you know, Tina, that smokers get more wrinkles at an early age and also are more likely to have back trouble? And the reason for that is smoking destroys collagen, which is what keeps your skin supple, important in the ligaments and discs in the back. Nicotine is an antidepressant, so it binds to receptors in the nucleus accumbens, releases dopamine, which gives you pleasure and acts as an antidepressant. It is very difficult, by the way, for people who are depressed to quit smoking. Some of them are self-medicating themselves, treating themselves with cigarettes. The other thing to know is that there is definitely a nicotine withdrawal, and there are a number of other symptoms people develop. In counseling people, you want to be honest about these things: constipation, anxiety, depression, irritability, insomnia, all those things, and give people strategies to help them cope. There's a weight gain associated with smoking cessation, which is on average about 7 kilograms. It is lost in about a year or so. So, for people who don't want to put on the weight, you can let them know that there is a temporary increase and then it goes away. Now, what's the benefit of quitting smoking? So, it reduces the risk of ischemic stroke by about 34%. And I can tell you there is really not a lot of medications that get that. It also reduces the risk of hemorrhage, and has an even more robust effect on the risk of MI. And the reason for that is MI is much more closely related to atherosclerosis than stroke is. Stroke, of course, has a number of different etiologies, one of which is atherosclerosis. Right. So, very brief advice to quit smoking. One thing is to inquire non-judgmentally on every encounter. Talk to them, clear, unambiguous, personalized advice. When you have patients with acute stroke in the hospital, one of the things that I tell them, which is very easy for people to picture, is cigarette smoke makes the blood stickier. It is much more likely to clog up a blood vessel and cause a stroke. And there is a lot of evidence for this. It increases the number of platelets, adhesion of platelets, increases hemoglobin and fibrinogen. The good news is those effects on rheology, on thrombosis go away in about 72 hours of quitting them. The other really important thing that we've gotten much better at and systematic at the general is acting on the patient response. NRT is offered to all smokers in the form of a patch on our unit. And I will tell you, it's less than 5% who refuse it, and some of them change their mind after they've been in hospital. The other things are Zyman and Champix. Now, these things both work in slightly different ways. Varenicline binds to nicotine receptors. There's an increasing dose that you can look up. Both of them have some cautions in people who have epilepsy or seizures. Um, Depression, and there have been a few studies on this, is probably an over-concern. It's probably an unmasking and a withdrawal from nicotine. By the way, both of them can be used with nicotine replacement therapy of various types. Now, so A couple of things. First is because we have seen it, as professionals, as society, that smoking and addictions at large are a personal failing, a failing of character. People often think that medication cannot help with that. So you want to let patients know that it is not a failure of character, that it is highly addictive, and medication doubles or triples their chances of being successful. Quit dates are important in the outpatient setting for hospitalized patients. Given the effect on stroke recurrence, on thrombosis, the quit date is really now. So, what I tell people is it's really important right now for you to have no cigarettes because they will make your blood stickier. By the way, the effect of cigarette smoking on stroke recurrence is greater than the effect of antiplatelets. So you might as well not even take the aspirin and clopidogrel. It'll be wiped out if you continue smoking. The other couple of things that help them is one of the reasons why people get anxious when they quit smoking is nicotine is an antagonist to caffeine. So if you are drinking a lot of caffeine and you quit smoking, your effective caffeine levels rise. You get far more kick, far more agitation and anxiety from a cup of coffee than you used to. It's a good idea to avoid alcohol for a few weeks because it turns out alcohol impairs judgment. We're far less likely to do smart things when we've been drinking alcohol. Shocking, I know, but true. And so, one of the things that happens is, as committed as a person might be to quitting smoking, alcohol inhibits the frontal lobes, reduces the barriers, and you smoke again. The other thing to let them know when you see them in follow-up if they've had a slip is those things happen, but they shouldn't be seen as catastrophic. You get back on the horse and get back to doing it. So speaking of coffee, one of the questions we commonly get with risk is, gee, could coffee have caused it? My wife, my husband drinks a lot of coffee, doctor, and could that be the cause of it? So we actually have a lot of data on that, and one of my favorite ones is this one, which is which is a massive study that was done in Finland. It's the Finnish smokers study. Now, this study really wasn't designed to start with coffee. What they were actually looking for was the effect of vitamin E. They thought, not unreasonably at the time, that vitamin E might prevent cancer in smokers. To cut to the chase, it does not. Vitamins are largely ineffective for vascular disease, for stroke, for dementia, for cancer, for just about everything we've looked at. Some randomized trials with vitamins show an increase in certain types of cancers associated with them. But just to get back to the story, why would coffee help anyway? Coffee and tea also, they're plant products. They're antioxidants, they're polyphenols, reduce oxidation of LDL and reduce inflammation in general. There isn't a convincing link to cardiac disease in cohorts. If you look at the evidence that's there and the advice, there is a caution, but not an absolute barrier to drinking more than 4 to 5 cups per day, particularly in people who are severely hypertensive. That level may increase the blood pressure. So in this study, they had vitamin E, the alpha tocopherol, and beta carotene to stop cancer, which didn't happen. 29,000 people. And as part of this, because they knew there might be all sorts of other influences on cancer, they did detailed assessments of vascular risks, food intake, and drink intake. Now, so enormous amount of data here, over 360,000 person years of follow-up. In Finland, it turns out that just about everybody drinks coffee and they drink a lot of it. So, in this cohort, 20,000 people, only 2.5% were not coffee drinkers. Almost two-thirds were not tea drinkers. The mean consumption was 5 cups a day. So quite a strong habit. And over 3,000 strokes in follow-up. Here's the results of it. So 4 to 5 cups, 6 to 7 cups. If you look at that odds ratio, 0.87, 0.76, two things. There is a dose response. So with more, there is a reduced risk of stroke, and it gets to be about at that 20% range in the higher end. So coffee largely doesn't cause stroke and seems to be protective. These effects were independent of blood pressure, alcohol intake, the amount of cigarettes. Remember, in this study, they're all smokers, whether they had diabetes or coronary disease. So for male smokers, you got this about 20% reduction in the risk of ischemic stroke with 2 cups of tea and 7 or 8 cups of coffee. Now, more than 4 cups of coffee per day increased the risk of stroke in interstroke, which was another observational study done from PHRI. So I think, and most of the people in interstroke were non-smokers. So it's possible that for smokers, higher doses were needed. And it's also possible that because the Finns drink 5 cups or more a day on average, there were relatively fewer people in lower dosage range to show that. But I think for most of our patients, we can suggest that intake is actually beneficial. There have been some studies on green tea that suggest a benefit as well. All right. So, well, one of the things we've been working on in our research group is to make our populations look more like the populations we treat. One of the significant issues in older cohorts has been the lack of women. So, what can we say about women? So there was a very nice study, the Nurses' Health Study, 83,000 women followed for over 20 years, and they had, over 2,000 strokes, including some hemorrhages. And they looked at the incidence of stroke modeled by coffee intake, and in this cohort, much lower doses of coffee, adjusted for all of the sorts of things we know can cause stroke. And this was the result. So on the lower end, now remember that the Finnish male smokers drank on average 5 cups a day. And in the Nurses' Health Study on the lower end, there was less than one per month. And, they topped out at about four a day. The nice thing here is that you saw an effect at four a day, which is a moderate consumption of about 20%, very similar to what was seen in the Finnish study. If you smoked, by the way, that benefit seemed to be negated. So, that moderate range, if you keep smoking, and again, think of the biology of it, what it does to thrombosis, cigarette smoke, it causes us problems. So, there's a dose-dependent benefit with about a 20% reduction in risk lost in non-smokers. By the way, they looked as well at decaf, and there's a trend to benefit with decaf. By the way, it's almost certainly the case that decaffeinated beverages have the same benefit. Again, it's not the caffeine that has it, it's all the other plant products that are in the beverage that's there. And to support that, there wasn't an impact seen with other caffeinated beverages. So, Steph, you cannot get this benefit by chugging Red Bull. And that's the bottom line on coffee. All right. So, you can have your coffee and you can, or your tea. I switched to tea recently because I find it more soothing without problems. Okay, what about exercise? So, in the Epic Norfolk study, exercise was one of the factors that really helped. Or conversely, a sedentary lifestyle led to a higher risk of stroke. So, what can we say and what advice can we give about activity? So this is a poll that Tina is going to launch. And what is the recommendation for adult weekly physical activity levels? And you have the choices there. You can read it to yourself faster than I can. So please vote now. Okay. And are we done, Tina?
I see a few more responses coming in.
Bit of a horse race here that I see.
Mhm. Yeah, I think we can go ahead. If anyone else wants to respond, they should do so quickly if they can.
All right. So if we look at the responses that have come in, the vast majority of people have chosen the first choice, 2.5 hours of moderate or 1.25 hours of vigorous aerobic activity and or muscle strengthening. Sorry, there's a little typo on the slide, um, and over the other ones. So and that is the answer. So that is, it's certainly a lot of data on there as CDC in the US and Health Canada subscribe to that. A couple of things. So what this actually is about 30 minutes, 5 times a week of moderate activity. For patients, usually this is something like walking. And what does moderate mean? Moderate means that it gets your heart rate up and more intense that you can't carry on a conversation. There is a dose response curve with this so that more intense activity, you need less than that. There are also recommendations for strengthening exercises, which reduce the risk of falls in our patients, falls and subsequent fractures, and as well improve metabolism in a number of ways. This is an older study done in British men. Again, the older epidemiologic studies were focused only on men. There is other data on women to support this. So there's the dose response curve. So if you do very vigorous exercise, you need relatively less of it to achieve the health benefit. It is there in women as well in the nurses' health study. And if you look at that relative risk reduction, that's 45%. That's a pretty gosh darn big benefit, in terms of stroke and heart disease, and a number of things. One thing to know about exercise is that exercise is what we call a dirty intervention. It's not one that's targeted at just one molecule, just one pathway in the body. It does a whole host of things. So when you exercise, your blood pressure goes down, your mood improves, interestingly enough, your sleep improves, inflammatory factors are reduced. The proportion of good and bad cholesterol is adjusted. So HDL increases, and exercise is one of the few ways to achieve that outside of certain medications, and none of them are very good at increasing HDL. And it works at any starting point and at any age. When I'm talking to patients, some of whom are very inactive, about how to start with it, it is to start with what you can tolerate. And if that means walking to the end of your driveway and back, then that's where you start with. And as you go on, as that becomes easier, you increase it until you get to that 30 minutes a day. We usually recommend, in the prevention clinic, the during the winter that people join a club that meets at a mall. And there are a number of these. They usually seem to meet before the mall actually opens, and the goal there is to walk at a sustained pace, not to stop and start as you do when you're shopping, for instance. By the way, frequently we get the question that my job is very physical. So I work in Stelco and I walk in the plant and all that. So I really don't need exercise. Um, what do you make of that stuff? Do people who walk a lot in their job not need exercise? People who have physically active jobs.
No, I would say that they still need a dedicated exercise. I think that the key here is the intensity level, and we want to bring it up to a high enough intensity level that there is a different kind of benefit that you would get from that kind of activity.
Great, great response. For those of you who don't know, Steph is very knowledgeable in many things, and this is just one of them. So, if you look at the data, there's actually an inverse correlation between physically demanding jobs and stroke risk, meaning that those who have more physically demanding jobs have a higher stroke risk. Now, that sounds weird. Why is that? And the reasons for it are as follows. First is exactly as Steph laid out. What they're doing is the same repetitive thing over and over again. It is not increasing the aerobic capacity. The heart rate isn't increasing. And actually, with repetitive activity, you can hurt yourself. I don't mean walking, but a lot of other things that people do in physically demanding jobs. The difference between leisure time activity and that is you do it at a pace that increases your heart rate, increases your aerobic capacity, is adjusted so as something becomes easier, you walk at a faster pace or go for a longer distance. All of those things are good. And by the way, for anyone who has a dog like we do, dogs are great at getting you outside. No matter how tired you are, no matter how wimpy the weather makes you feel, the temperature, precipitation, whatever, dogs need to get out. And so you get out there and do that. And, certainly our dog, for both my wife and I, has resulted in increased activity. We also meet more of our neighbors, everyone who's out there walking and walking their dog. All right. Two other things I want to get to, which are topical. The first is the effect of COVID-19 on stroke risk. One thing to know, so this year is the first year since 2020 when there have been more deaths and hospitalizations due to flu than COVID. For each of the last 5 years, apart from this one, COVID has caused many more deaths and hospitalizations. By the way, in North America, about 20,000 people a year die from the flu. It is commonplace, and so we think it's not meaningful, but yet it is. Now, COVID actually has a greater risk of stroke and a number of other things than the flu. And this is the bottom line. So that study in Nature Medicine, if you looked at people who had already survived COVID, so 30 days later, and you looked at the risk over the next year, and it's limited to a year because that's as long follow-up as they had, you see an increase in the risk of stroke, TIA, and atrial fibrillation. Remember that TIA, many of those will be minor strokes, just weren't imaged. Atrial fibrillation will be a risk factor for stroke. So at a population level, while these are small absolute risks in an individual, so many people have been infected with COVID that we can expect to see this ongoing increase. Now, the risk is proportional to the severity of the COVID. So if you're in the ICU, much more likely than if you were never hospitalized, but that risk increases there in all categories. And it is independent of other factors in that person. I think one of the more common types of stroke we've seen are relatively young people who don't have other risks. At the bottom, by the way, is, kind of the expectation in this country of up to 20,000 more cases related to this pandemic. It's not all bad news, however. And one of the things you do want to talk to your patients about is vaccination. This is a randomized trial of vaccination for the flu after MI. So what they did was they took patients who had an MI, randomized them vaccine or placebo, and there is a hazard ratio, almost a 30% decrease in recurrence of MI in people who are vaccinated. And by the way, we have data on stroke as well from Ontario. So administrative data, which really suggests that if you had the flu vaccine this year, your risk of stroke is 30% less than it would have been otherwise. So when I'm talking to patients, I tell them that I consider vaccination just like their medications. It is an aspect of stroke prevention. All right, here is that thing I promised you would come at the end, which is the ranking of these things. Now, because of the question, what you've got to do is move those things up and down to find the one that you think has and we'll do it just so we're consistent. At the top should be the one you think has the highest benefit, so the greatest relative risk reduction, and at the bottom is that factor that has the least. So please vote now. And we should have set up music, Tina. Like Jeopardy or something.
Go ahead. You can
Well,
hum along.
I am a terrible, terrible singer.
All right, we're up to 6 responses.
Great. Good job. So if you haven't put it in, please put it in now. All the data on tea and coffee was a great relief to me. I've been addicted since medical school. Yeah. And, it was during COVID, I switched to tea because I was finding that the high test coffee was giving me palpitations. Never used to. And then it started. Probably because I was less active. Sorry, go ahead, Steph.
I was conveniently drinking a coffee when you were talking about the coffee part. It was comforting.
So, Tina,
Okay,
if you
I'll
can,
close the poll now.
Great. Look, and just looking at what I see in the poll, it looks like people had a pretty good idea of what works and what doesn't. Here are the results. So blood pressure reduction of 10 millimeters of mercury reduces your risk of stroke by 40%. Aerobic exercise, 2.5 hours a week, is the most effective at 45%. Aspirin has about half that, right? So 20% with aspirin. Statin therapy is better than aspirin, 25 to 30% risk reduction. And 2 cups of coffee, about as good as aspirin, 19% relative risk reduction. So there's a summary there. I'm happy to address any questions you might have, questions about things we didn't cover. I have no idea if my colleagues who gave the last 2 talks did a good job of talking about, I don't know what they talked about, but feel free to ask if you have any questions or concerns. Vicky, how much coffee do you drink? You have
Well, just 1 a day. I guess I need to increase my amount I'm drinking.
2 might be better, Vicky.
Okay. And I have a tea though.
Well, that works perfectly well.
Phew.
Okay, well, thank you, Dr. Sharma. And given that this is a meeting format, you can simply unmute if you like, or raise your hand as Shirley has done. So go ahead.
I have a quick question that I'm a bit curious about. I know that when it comes to like the Black population, especially from the Caribbean, they are at a significant risk for hypertension. But in the hospital setting, what I see, I don't see many of this population showing up like inpatient on the inpatient floor for treatment. So so the question is, I guess the question is there, do you have a study? Are they more, I'm thinking because they're at higher risk for, for hypertension, there should be a higher population of people with stroke, but I don't see them. So that's my question. And I don't know if you've got a study about that and why.
Yeah, there are a vast number of studies on that. So the answer is that Black people are at higher risk for hypertension. You're absolutely correct. Are less likely to have their blood pressure controlled and have a higher risk of stroke at an earlier age than other ethnic groups. The reason you don't see it a lot is because the population is relatively small. We see it in the outpatient clinic. We see it here as well. So a lot of the data, comes from the US, where you have much larger populations, and that is consistently seen. It's true as well for Hispanics in the US. And when these things come up, we're tempted to think of things like genetics. It's almost never genetic, these differences. They do have to do with health behaviors, health literacy, but also access to and interaction with healthcare. So one of the things that's true in all of these are our Black patients are less likely to have consistent primary care, which is reflected in the lower rate of control of blood pressure. So first off, you have people who are more likely to have it and then less likely to have it controlled, all of which contributes to an increased risk. Any other questions?
Yeah, feel free, you can put it in the chat and we can read it, or you can unmute yourself and ask.
Is there a genetic component to Black people having more, being a higher risk for high blood pressure resulting in stroke, or is it more environmental or social?
So we think mostly environmental and social. In terms of genetic differences, there's a feeling out there that there's a higher um, uh, prevalence of hyperaldosteronism, which is one thing that results in hypertension in Black patients, though that data isn't there. I think before we start digging into the smaller genetic differences, by the way, so if you try to define a race genetically, it's really almost impossible to do. You can't come up with a set of genetic markers that divide us into races because we are so close to each other. I mean, over 90% of our genome is also shared by chimpanzees, so you can imagine how close people are if that's the case. The health behaviors, literacy, access, all of those things have a much greater impact than the smaller genetic differences. So, if you look even at all of the social factors that drive health risks. They're all concentrated more so and a lot of this data is from the US, but we can replicate it more so in certain communities. So this includes not having access to a affordable source of food. One of the things to know is that 2 liters of Coke costs exactly the same everywhere in this country, and go to Nunavut and buy it for about the same as you can here. A head of lettuce, however, varies tremendously depending on where you are, where it's got to be shipped, and all of those. There are food deserts. If you look at the area right around the general, right around our hospital, right around where we work, it has one of the highest areas of incidence of a number of things: diabetes, hypertension, stroke, and heart disease. The life expectancy there is 20 years less than the life expectancy where I'm sitting right now in Ancaster. And that has to do with a lot of these other factors. Um, Hospitals, by the way, are commonly placed in poorer sections of cities because that is where illness is there. The life expectancy there, by the way, down in that area and in portions of Hamilton is about the same as it is in India. So there is a difference in all of that access that we have to food, to green spaces, to leisure time, to primary care. So there is a difference in the proportion of people here who have a family doctor and the proportion there. Michaela, please unmute yourself and
Hi there. Um,
hey.
I'm conveniently listening to this while on my lunch walk, so I was happy to hear about the benefits of exercise. Just a question though about the smoking cessation. Does the smoking research only talk about people who are smoking tobacco, or is it also for people who vape or smoke marijuana? And I'm sorry if you spoke to that earlier. I was just a little bit late to join.
No problem at all. Fantastic question. Here's what we know. If you look at summary statistics about marijuana, what it will say is, gee, we're not sure. The actual truth is, it absolutely does increase the risk of vascular disease. The reason we're not sure is because we haven't had large studies. Up until very recently, and maybe even now, people didn't want to admit they smoked or how much they smoked. The second issue is that the dosages compared to tobacco for marijuana were relatively less because it impaired your ability to perform. By the way, in very high daily users of marijuana, it doesn't seem to have that much of an impact on people, similar to what are referred to as functioning alcoholics. There's a lawyer who smoked many, many joints a day who was pulled over on a traffic stop and cited for driving while impaired because he reeked of marijuana. He went to court and said, yes, I smoke all day, every day, but I'm not impaired, and proved it to the court. The thing, however, to remember is it's not the cannabinoids, it's not the nicotine that causes the health risk. It is the products of combustion. So basically, if you take a step back from it, what we're saying is, if you take these leaves, dry them, burn them, and inhale the smoke, it's bad. But these ones over here, gee, we're not sure. And the honest truth is that many of those in the laboratory, many of those chemicals are exactly the same. You've just taken plant matter and burned it. So marijuana smoke is not a good idea. So when I talk to patients, and a number of our patients rely on it, mostly for mental health issues, for anxiety, for stress, for sleep, I advise them to use it in a different way rather than burning it. Vaping is one of those ways. Edibles are another one. That is the best advice we can give. Marijuana, by the way, is also related to reversible vasoconstrictive syndrome. So it's one of the causes in young people of arteries in the brain suddenly closing and causing stroke, a nasty condition, but we've seen a number of cases on our unit. Now, your second question, which was a great one, was about vaping. Here's what we can say is that we have less data on vaping. There are concerns about other long-term effects of vaping. In vapes, there are things like heavy metals. And what happens to somebody who does that daily for 20 years? That kind of data we don't have. Where it fits in is in harm reduction. So if we have a smoker who just can't quit, and there are a lot of things about smoking that are addictive, including having something in your hand and sticking it in your mouth, I would rather have them vaping than smoking a cigarette. I tell them that there are potential other adverse effects, but between the two, the risk for recurrent stroke is much higher with smoking.